No, thank you. So I appreciate you coming. I appreciate your attention. And we'll start with the cases. And especially at the end, I'm interested in any feedback you have on the lecture. I obviously want to make it better each time we give it. So we'll start with case 1. So fire and EMS dispatch code 3 to industrial facility. And I'm going to give you the time to read the narrative because I think this crew did a really nice job of documentation here. And then for those who are listening remotely who might have a hard time, I'm just going to give a brief summary. But a 45-year-old male, 15 to 18-foot fall, complaining of some neck pain, had some paresthesias, felt weaker in his upper extremities. And then this is a second case, and this was code 3 dispatch to a home. Nature of the call was injury, and it was an 11-year-old male. So in brief summary, wrestling with his older sister, neck was flexed forward. They reported hearing a loud crack, and the patient cried out in pain. He said that he could feel things, but that things felt different. And again, I just wanted to commend the crew. This really, really detailed description of the scene, what the patient's symptoms were, what the findings were on arrival. So these are my learning objectives for today. We're going to do a brief overview of anatomy and physiology of the spine. We're going to review some of the key injury patterns that we want you to look out for, review the management, and then we're going to review some of the key points in the documentation. So to start out, take case 1. What were some of the strengths of the documentation there? Yeah, that's a very, very clear description of the scene, very clear description of what was going on. Other strengths in the documentation.
Mechanism of injury.
Yeah, very clear description of the mechanism of injury, but not just the degree of the fall, but how the patient fell.
Pertinent negatives.
Yeah, so the pertinent negatives are covered in the pertinence findings, and it's very clear for someone reading this history, like what is it that the patient was complaining of, what is it that the medic found on assessment. And then what about the second case? What are the strengths here? Yeah, so they got in this pertinent previous history for the patient. Yeah, real description of the physical exam, how things flowed, but also what the patient was complaining of, and in his own words. And I've truncated a little bit of the management here, but they also did a nice job of describing the flow of the call and how the case was managed. And both of these are cases that we've had in the last couple of months here. So we'll go into a quick overview of anatomy and physiology. I know this will be a review. So 33 bones. It supports the skeletal structure. It's a protective container for the spinal cord. The vertebral body, this large body of bone here, is the major weight-bearing component, and it is anterior to the other things. So when you're palpating the spine, you're palpating the spinous processes, but what bears most of the weight is furthest from you. So the cervical spine, 7 vertebrae with one really unique arrangement. So C1, the atlas that supports the head, pivots on C2, the axis, which includes the odontide process. But you can imagine that is a relatively weak point in the whole system, because you've got the whole, everything necessary for the distal innervation of the body supported by this one fairly thin piece of bone. Other key feature in the cervical spine, you can all reach back and feel vertebra prominens is C7, and so that's a good landmark for you when you're figuring out, okay, how high up am I? And then it also is a marker for where the thoracic spine starts. The other unique thing about the cervical spine is that you have the vertebral arteries that are running through the vertebral foramen. To go back to the cross section. So in these holes just to the outside of the cervical spine, you've got these arteries running through. And so that protects them, but with sharp rotation puts them in a uniquely vulnerable spot. Although it's not common, this is probably why I've never seen an ER doc go to a chiropractor for a neck adjustment, because we occasionally we'll see damage to the vertebral artery with a sharp twist or sharp adjustment. But we'll also see vertebral artery injuries and other traumatic injuries. And so, and the real problem with a dissection, you can disrupt the blood flow, but you can also just get a little tear in the intima, and that serves as a place that clots can go up. So people that have vertebral dissections, a little bit counterintuitive, but we actually put them on blood thinners to keep them from forming clots where the intimal part of the vertebral artery is damaged. So the thoracic spine has 12 vertebrae. They're much larger and stronger than the cervical spine, and then unique in that they're associated with the ribs. So you got the first rib articulating with T1. First rib is a very large rib. Damage to the first rib implies really significant trauma. Then you've got the attached ribs, and then below that, the floating ribs. So they not only have the ribs supporting them, they've got much more musculature around them. And then the lumbar spine, the 5 vertebrae, they bear the greatest amount of weight and are the strongest. They have the largest and the thickest vertebral bodies, largest and thickest discs. So I had a long slide of pediatric considerations. Think of kids like darts. They just have this very heavy thing on the end that and then they tend to fall on that. And then everything else is weaker downstream from that. So bigger head, weaker musculature. And so as you're assessing mechanism of injury in a pediatric patient, just think about this heavily weighted object falling towards the front. So there are tracts that run up and down the spinal cord. They're descending tracts that provide motor control, and then ascending tracts that provide sensory control. And the key point that I want to make here is that depending on where the spine is damaged, you get depending on where the spinal cord is damaged, you get different pathology. So the dorsal, as far as the sensory tracts, the dorsal columns along the back, that's what's responsible for the sensation of deep touch, like when you're feeling deep pain, proprioception, meaning sensing where you are in space, and then the vibratory sense. Again, these are not things that you're going to test in the pre-hospital setting, but someone who's had damage to the dorsal column, they're not able to understand where they are in space. So you have them stand, close their eyes, they can't stay standing up because they can't maintain their proprioception. The lateral spinal thalamic tract is responsible for pain and temperature sensation. So that's what's responsible. You reach out and you touch a hot stove, you retract from that. That's sensed through there. And then the ventral spinal thalamic tract is responsible for light touch. And that's typically what we're assessing in the pre-hospital setting, because that's what's fairly easy to assess. But understand you only, as far as the sensation, you're only assessing part of the sensation when you assess for light touch. But I don't think it's not reasonable to try to assess for temperature in the pre-hospital setting. Then as far as the descending tract, you have most of it is voluntary motor control, but then you also have some involuntary motor control that comes through those descending tracts. And in terms of sensation, where the patient feels is roughly divided into these dermatomes. So you have the sensation roughly corresponds to the spinal level. If you're taking care of a patient who has had a previous spinal injury, they will almost always know what their spinal level is, and you'll see the symptoms that are associated with that. So it's some rough landmarks here. So remember, all the way through everything that innervates down through the hands, it comes from the cervical spine. The level of the nipples is a level of T4. T12 is innervation down to just above the pelvis. And then think of this, the innervation comes, if you picture a four-legged creature, it makes more sense, because so the S1, S2 is what would be like around the tail in a four-legged creature. So these deep roots along the back, and then the innervation along the outside of the foot, that comes from the sacral nerves. And so obviously the rectum is the lowest sensation that you can test on the spinal cord, but the outer toes are right around that level as well. So that's sensory level, and then there are motor levels as well. And again, my focus in this is not to have you memorize these and be able to rattle off, but when you do something, as these crews did in those cases that I showed, when you give a good description of what you're finding, what the patient's able to do and not do, what the patient's feeling and not feeling, then that gives us a clinical exam to go with what's going on, especially if this is a patient that's getting RSI'd. That initial neurologic exam is critical, and we really depend on what you find in the field. So in terms of motor, the cervical is responsible for the muscles of respiration. You probably heard in school, C3, 4, 5 to stay alive, because that innervates the phrenic nerve, which controls the diaphragm. Going the lower part of the cervical spine that goes out through the brachial plexus innervates the muscles of the hand and the arm. And again, rather than memorize these, just describe really clearly what you're finding. What are they able to move? Are they able to, flex their bicep? Are they able to move their tricep? Are they able to grip? And then in terms of the thoracic spine doesn't have much motor control. Just mostly core muscles there. And then in terms of the lumbar spine, you're getting into some of the lower abdominal muscles, gluteus and the thighs, the abductor muscles, medial thigh, and then the sacral nerves just control essentially movement of the toes, movement around the rectum. Any questions about the basic anatomy tract? Okay. So now we're going to go into the pathophysiology of injury. What happens? And so we're going to review mechanisms of injury and think about what would be associated. So think about a flexion injury. Someone gets flexed forward, as we had in this 11-year-old. What are the things that are most likely to be injured in that situation? Cervical, because you've got the most flexion there, and especially the anterior, the vertebral body is really at risk because you're having this sharp force that's applied there. What about compression injury? What's most at risk for that? Yeah, cervical again, this is the weakest, the least protected spot. You're talking about a heavy loading mechanism. You can get complete destruction of the vertebral body. The posterior elements are at risk as well. But the other thing that we do occasionally see suffer from compression injury is someone who has a really significant fall. If you so you have a really significant fall, land on your feet, what part of your spine is going to take the greatest brunt there? Yeah, thoracic lumbar, especially at the junction. So where the classic one is like an L1 or L2 fracture after a heavy loading injury. So we see someone who falls, hits on their feet. We worry about calcaneal fractures, heel fractures, and then especially L1. And right around that junction where you're changing from being supported by the ribs to just having these strong vertebral bodies, that's where they most often injured in a fall like that. So in a distraction injury, so talking about distraction, I just can't get over the fact that this guy is wearing a tie. But there you get the elements pulled apart. This is unfortunately something that we'll probably all see at one point during our career. So hyperextension injury, there the posterior elements are particularly at risk as they're getting flexed backward. And so, I mean, as suggested in the picture, this is something that you most often see in motor vehicle accidents. And then the flexion rotation injury typically are related to significant falls. And then you can also have penetrating injury to the spine. So one thing we can deal with is an injury to the column. You can have fractures, you can have subluxation where it's just moved out of place, or a frank dislocation. You can have rupture to a disc. So C1 and C2 are the most delicate. Around C7, you get that transition from the flexible cervical spine to the rigidity of the thorax, so you can get fractures there. There's also a stable fracture that we see called the clay shoveler's fracture. That's right at that C7 vertebra prominens, and so it's typically someone you picture like taking a shovel, digging it into clay. You're pulling up really hard on that, and you can break off the spinous process there. That's a stable fracture, but it's still quite painful. And then T12, L1, where you get to that area of different flexibility. So right at those junctions, those are the places that you're most likely to have an injury to the column. And then when we see an injury to the column, what we're trying to figure out is, okay, is this a stable fracture or is this an unstable fracture? Then you can get, what we really care about most is injury to the cord, because that is going to affect the neurologic function. That's something we're typically going to sort out on MRI. This is an MRI image here. So the cord can get concussed, just like the brain can get concussed. It's nervous tissue with gray and white matter. It's temporary, it's transient, but in the field, there's no way to tell concussion from a contusion or another injury. So the contusion is bruising the cord. You can get swelling around the cord. The cord can be compressed, or you can get either a complete or incomplete transection of the cord. So here you've got a bony injury in the mid-cervical spine, and then it's compressing the cord. So there are a few syndromes that we're going to review, and this kind of helps lock in the stuff that we're talking about with the different tracts. So the anterior cord, so the anterior cord is what carries that sense of light touch, and also some motor function. You're also getting into some of those pain and temperature sensations. But you preserve the dorsal columns where you have that fine touch and then the proprioception vibration. And so this is typically it's a vascular distribution, just like a stroke. So you have an MCA stroke, has a certain pattern. An anterior spinal artery injury has a similar pattern. So you can see this with penetrating trauma. You can occasionally see it with blunt trauma when the vessel is disrupted. You can have a spinal stroke, where you see in a non-traumatic situation where the anterior spinal artery just gets occluded. But that's why that documentation of exactly what you're finding, what are you finding in terms of motor, what are you getting in terms of light touch, that becomes really important. Then you can also get a central cord syndrome. This is something that we see much more commonly related to hyperextension of the cervical spine, typically in older people with degenerative disease. And you get, because it's in the cervical spine and it's around those central motor tracts, you typically get weakness, and it typically affects the upper extremities more than the lower extremities. You can also get bladder dysfunction with that because it disrupts some of the tracts that innervate the bladder. But that's why that detailed description of exactly what the patient is feeling and what you're finding on your initial exam is really important. And then this is probably the more rare, but pretty interesting. So this is the Brown-Séquard syndrome, and that's a penetrating injury to one side of the cord. And so on the same side, you lose sensory and motor function on the same side of the injury. And then on the other side, because they're cross tracts, you lose this sensation of pain and temperature. What's that going to look like? One, you're going to have a history of a penetrating injury. But two, you're going to say, well, this I can feel, this I can't. So although we normally think of spinal, we think of spinal levels moving down, especially in a penetrating injury, it's possible that one side of the cord can be affected. And so you want to describe what you're finding on each side. And what you're not going to pick up the temperature loss unless the patient is saying saline spills on the patient's leg, and that they don't feel that, or it feels hot when it should feel cold. But we are going to notice the loss of pain sensation in that area. So the signs and symptoms. This is something that you're going to find much more with your physical exam than with what the patient is describing. Again, going back to those cases, I think both of those medics did a great job of describing what the patient is feeling, the numbness, the back pain, and where they are feeling it. But in terms of your signs, finding that midline tenderness, finding objective weakness, finding decreased sensation, obviously if you're finding impaired breathing, noticing a deformity. So priapism, if you disrupt the spinal cord in a man, you can get an inappropriate erection that persists, and then you can find incontinence to urine or stool. So you can get spinal shock and neurogenic shock. Spinal shock is temporary. Again, this is not a distinction that we can make in the field. So spinal shock does get better, but both of them involve hypotension. You're typically going to see that the patient is not losing motor control. You can also see priapism, and then these are patients that tend to be bradycardic. So this is, in general, the one situation where you might consider a pressor in a trauma patient, because the problem is that they're just losing their ability to maintain their vascular tone, and so their pressure will drop. It's a very distinct situation versus the person who's hemorrhagic, tachycardic, and then dropping their pressure. This is a trauma patient that's bradycardic and hypotensive. And there's going to be some other neuro finding. I've never seen this happen without some sign of a neurologic injury. Any questions about pathophysiology? Okay. So we'll move on to evaluation and treatment. So as you noticed in the case, a good assessment of the mechanism, and I just can't, you don't always hear it, but in the hospital, we depend so much on the description that you give of the mechanism, both what the patient described and what you noticed, and that sense that this doesn't quite make sense, or this person says they fell down one step, but they're bruised all over and they're at the bottom of a flight of steps. That's really critical. Remember, these are trauma patients, assessing circulation, controlling any hemorrhage, and then the airway and the breathing, and then getting your neurologic evaluation, both what the patient is complaining of and then what you're finding. And then as these, documenting both what you're finding initially, what you find after immobilization, what was the effect of your interventions, but that thorough documentation throughout. So especially those of you who have been doing this some time, have seen some shift in the way we approach spinal immobilization. And so there's now a joint statement by the National Association of EMS Physicians and the American College of Surgeons Committee on Trauma. And so we're trying to be judicious in the use of the long backboard. This is definitely an extreme case of someone who was left on a backboard for a long time and developed a pressure ulcer, but we do see patients who have increased pain. We do see patients who have other problems related to the long backboard. So just like any other intervention we do, we're weighing the risk against the benefit. There's some things that we don't have to think about that much. So the risk of defibrillating someone in VFib, the risk benefit is clearly there. The risk of giving someone diltiazem and rapid AFib, still pretty good. But then this is one of those interventions that we don't have a lot of data to support and does have some potential side effects. So we're trying to be judicious in the application. This is something that we think probably makes sense to not move around people who have a lot of spinal injuries, but there's never been a large study that proves that we save lives by putting people on long backboards. On the contrast, when we give aspirin for someone who's having an acute coronary syndrome, we know that every 42 times we do that, we save one life just by giving aspirin. We can't say that for long backboards. That said, we also think it's probably reasonable not to have major motion in someone who has a spinal injury, and it can be a valuable tool, especially for extrication. So patients that we are using the long backboards for, so a blunt trauma with an altered level of consciousness, if there's spinal pain or tenderness, a neurologic complaint, a deformity that you're able to see or feel, and then a high injury, mechanism of injury, where the patient is intoxicated because of their injury, has lost their inability to communicate, or it can even be, say there's a language barrier that you can't get across. That would heighten that would make you less able to rely on your history and physical to make a decision about this. And then a distracting injury. And in clinically, the things that the most underappreciated distracting injuries that we have are some kind of injury to the torso. Like if someone has rib fractures, that's something that commonly can distract someone from a spinal injury. If someone has a broken toe, less likely that that's going to distract them from a spinal injury. But it also depends on the reason we leave this as a clinical judgment is when we studied it, when we study who do we need to X-ray or CT with spines, the study was left up to the judgment of the clinician. Do I think that this patient could be distracted by this injury? So patients in whom we can avoid the long backboard, a GCS of 15, no spinal tenderness or deformity, no neurologic findings or complaints, no distracting injury, no intoxication. And a penetrating injury is not someone that's not someone that you need to immobilize. If you have a neurologic deficit, then the caution would be, but the priority in that patient is rapid transport. So essentially what we're saying is if you can trust your exam, then these are patients in whom you can avoid immobilization. So cervical collars have their own downsides. They can be uncomfortable. They can cause pain. The downside, they obscure your view of the neck to some extent. The downsides of the cervical collar are much less than the downsides of the long backboard. And so in a patient who's ambulatory at the scene, if you're doing an interfacility transport, you don't have another indication for a long backboard, then a cervical collar alone with attention to moving the spine with caution is reasonable. Trauma system activation, the policy in this county is that if you're having trauma activation from a blunt mechanism, you need at least a cervical collar. If long backboard if possible, if there's a deterioration and for some reason that's not possible, then apply the cervical collar and immobilize the patient to the gurney. This is a case where it really matters to document your reasoning, what you're finding clinically, and why you chose to do or not do that. So to review the assessment, You're going to do your trauma assessment. Remember to have a heightened index of suspicion in elderly patients. Other patients that you want to have a heightened index of suspicion, someone who's on long-term steroids, so that could be like a really brittle asthmatic, but anyone who, someone who looks frail, someone who has rheumatoid arthritis is actually a much higher risk for a spinal fracture, because the same thing that happens to the joints in the extremities also happens especially around C1 and C2. So patients who have weak bones, the elderly patients on things that make them osteopenic deserve extra caution. Multi-system trauma patients obviously have significant mechanism of injury and many potential distracting injuries. So in the neck, you're going to evaluate for deformity. In the extremities, you're going to describe the motor findings, sensory findings. We see dermatoma and myotoma evaluations, basically what can they move, what can they feel. Body temperature, just noting clinically if they, if they have a cold leg, something like that, noting the pulse and the blood pressure, and then continuing to reassess your interventions and reassess the neurologic finding. So the safest position is to move the head into a neutral inline position without causing any additional harm. If you have a patient that especially if you're putting them on the lying backboard, a little bit of flexion in the hips and the knees can decrease the amount of discomfort in the spine. Rolling the back rafts are really helpful in decreasing the discomfort from the long backboard. Support to the head and the neck. As you know, some patients, you can get them in a fairly neutral position, just on a long backboard or on the gurney. Some patients, especially those who are really kyphotic, really obese, you may need to do padding. The goal is ultimately to maintain a neutral spine to the best extent you can. When would you not maintain a neutral position? So movement causes an increase in pain, you're meeting resistance, you get a change in the neuro exam, or if you have some gross deformity of the spine, so like, midway through the thoracic spine, things take a sharp left turn, then that's not a fracture you want to reduce. In general, minimizing the movement and keeping them in the most stable position possible. So if in neurogenic shock, start with a fluid challenge because you may be able to resolve the problem with that. And then, like I said, but I think in this case, if you're needing pressors, I think that's worth a call to medical control. In the combative patient, you can consider sedatives. Especially, the intoxicated trauma patient. These can be patients that are difficult to immobilize. You're always trying to do what you can non-pharmacologically, but someone who was intoxicated and just ran the car into a post at 60 miles per hour, your ability to reason with them may be limited. Versed is ideal in this situation. Because it's relatively short acting. So, you give a significant dose of Versed, in 2 hours, I essentially have a normal neurologic exam. And so the short acting nature of it is really ideal for this. But if you've got someone who's really combative, there are cases where those need to be paralyzed and intubated with caution. So just a review of the procedure. So you're selecting the appropriate patients when you're doing full spinal immobilization. Documenting the mentation, level of consciousness, both a reported history of drug ingestion and what you're finding. So I think most of us are pretty familiar with what someone intoxicated with alcohol looks like. What about someone intoxicated with methamphetamine? What does that person look like? Louder. Great. Yeah, crazy, hyperadrenergic, tweaking, tachycardic, often sweating, combative, and then trust your judgment. And we're dealing with this big unknown now because we're now seeing, marijuana is now legal and much more widespread, and not something that's immediately clinically apparent. So I think that would just be one more thing to, raise your judgment, to raise your level of suspicion. Like, could this patient be intoxicated? if there was a loss of consciousness involved, you have to question, have they fully returned to their normal mental status? The assessment, your objective findings, and if you're finding anything abnormal aside of mobilization, if there are no indications for immobilization, then you don't have to immobilize. And then penetrating injury is a separate situation. The reason that penetrating injury is a separate situation is that we're in a blunt injury, we're thinking multiple fractures, you might have unstable fragments. In a penetrating injury, typically whatever damage to the cord is done is already done. And then, as a reminder, you can modify the spinal precautions if you don't have an indication for a long backboard, with special attention to trauma system activations. So going back to the cases, so the patient in case number 1 fell backwards. He had C6-7 fractures. The neurosurgeon saw him, and ultimately we did an anterior discectomy. They did a fusion. He had had some paresthesias that ultimately resolved. He was discharged in good condition. Case number 2, the 11-year-old male, he had a negative CT of the head and the cervical spine. He ultimately had a negative MRI of the cervical spine as well. This is something you may see in your old textbooks, or probably when you went through training, you may have heard of the concept of SIWORA, spinal cord injury without radiologic abnormality. We don't really use that term much anymore because we now have MRI and it's fairly readily available. So if there's a significant spinal cord injury, we're going to see that on MRI. But this is someone who, several years ago might have, fallen in that category for a brief while because he had some paresthesias for a while, but things ultimately got better. He left the hospital the next day, but got very appropriate care. So just a brief review of the learning objectives. So we reviewed the anatomy and physiology of the spine, special attention to the unique things about the cervical spine, the vertebral arteries that run through them. Remember that the junctions between cervical and thoracic and lumbar are areas of high risk for injury. We went over a few key injury patterns. The central cord syndrome especially is something that with our elderly population we can see. Remember looking for that increased weakness in the upper extremities, often after a ground level fall. We reviewed the management and then the key points in documentation, a really clear history of what happened, a really clear description of what you're finding, and then how the patient responds to interventions. Any other questions? Okay. Thank you, guys.